A research group from Helsinki University Hospital and the University of Helsinki presents Neonatal Hypoxic-ischemic encephalopathy, or HIE, affects between 1 and 4 per 1,000 live-term births. It remains one of the leading causes of neonatal mortality worldwide. Among survivors, outcomes range from mild developmental delays to severe lifelong disabilities. The underlying causes of HIE are complex and often include a combination of hypoxia, ischemia, inflammation, and metabolic or genetic factors. We conducted a 20-year population-based study across 7 maternity hospitals in the Helsinki region between 2005 and 2024. Out of over 317,000 deliveries, 314 cases of term HIE were identified, corresponding to an incidence of 0.99 per 1,000 live births. Our study focused on singleton newborns at or beyond 37 weeks of gestation, excluding those with congenital anomalies or genetic disorders. Recent reviews have highlighted the need for further research regarding the use of admission cardiotocography, or CTG, in laboring and non-laboring women, and have emphasized the importance of standardized definitions for avoidable perinatal brain injuries. Against this background, our study aimed to evaluate the impact of intrapartum asphyxia on neonatal HIE and to assess how many cases might have been preventable. Our objective was to assess the impact of intrapartum asphyxia, specifically indicated by umbilical artery acidemia, on the development of neonatal HIE. Additionally, we aimed to identify the proportion of these cases that could have been potentially avoided through improved intrapartum care. In a preliminary analysis of over 23,000 elective cesarean deliveries without uterine contractions, we found that no cases of HIE occurred among newborns with normal admission CTG. In contrast, HIE was diagnosed in 13 cases with abnormal admission CTG. These results suggest that a normal admission CTG reliably excludes preexisting fetal distress. In our integrative study design, we compared HIE cases based on admission CTG results. Cases with normal admission CTG were considered intrapartum exposures, while those with abnormal CTG were categorized as antenatal exposures. Extensive clinical, biochemical, pathological, and neuroimaging data were collected to support the analyses. Almost all HIE cases showed significant acidemia at birth. Severe acidemia was more common among cases with normal admission CTG, whereas moderate acidemia was more prevalent among those with abnormal CTG. Umbilical vein erythropoietin and serum S100 beta concentrations were higher in newborns with abnormal admission CTG, suggesting more prolonged exposure to hypoxia prior to birth. Placental pathology revealed that newborns with abnormal admission CTG had a higher prevalence of lesions indicating fetal or maternal vascular malperfusion. In addition, clinical and histological chorioamnionitis was more common in HIE cases with normal admission CTG. Using a detailed flowchart, we identified potentially avoidable HIE cases based on sentinel events, delays in emergency cesarean sections, and prolonged fetal heart rate abnormalities. Our findings underscore the critical role of optimal intrapartum care and early fetal monitoring. Improving labor management and timely interventions could significantly reduce the incidence of HIE and its long-term sequelae. These insights can guide efforts to enhance maternal and neonatal outcomes worldwide. We found that 50% of term HIE cases with normal admission CTG were potentially avoidable. This means that 22% of all term HIE cases could have been prevented. Admission CTG demonstrated 100% sensitivity and negative predictive value for ruling out preexisting fetal hypoxic injury, with 95% specificity. Furthermore, HIE was 11 times more common among those with abnormal admission CTG. Our findings underscore the critical role of optimal intrapartum care and early fetal monitoring. Improving labor management and timely interventions could significantly reduce the incidence of HIE and its long-term sequelae. These insights can guide efforts to enhance maternal and neonatal outcomes worldwide. Thank you for your attention.